Okay, I think we can get started. I'd like to welcome you all here today. Is this on? Do we have anyone down? It's on, okay. My name is Ann Case. I'm a professor of economics here at Princeton, and I'd like to welcome you to a panel discussion we're having this afternoon to celebrate the art from Philani, which you will see in the Bernstein Gallery outside. And I hope you all will have a chance to look at it after the symposium today. So today we have three panelists who are each going to talk on what works in terms of providing health or improving health in poor countries. So we'll work in turn, and our first panelist is going to be Dr. Ingrid Roux, who is the founder and the medical director of Philani, which is a nutrition program outside of Cape Town. Dr. Roux is also an MPP class of 01 from Princeton, and she also comes and teaches task forces here at Princeton on a regular basis, for which we are very, very lucky. So I'll turn it over to Dr. Roux.
Thank you, and thank you for this invitation to talk about Philani. The small group of women who gathered in Crossroads, an illegal squatter community outside Cape Town in the late 70s, were unaware to discuss what could be done about child undernutrition in their community, did not know that they were looking at the local expression of a worldwide silent emergency. Undernutrition, or what I in this presentation will call malnutrition, was and is a contributing factor to more than half of the 10 million child deaths a year worldwide. And in the case of more than 80% of those deaths, mild to moderate malnutrition is the contributing factor, most often not revealed by the appearance of a child. That meeting was the beginning of Philani, a community-based organization which is today operating in 10 different informal settlements on the outskirts of Cape Town. These sprawling urban settlements contain a population of about 750,000 people, with less than 15% living in formal houses, and with an unemployment rate estimated to be about 50%. Almost 20% of the population are children under the age of 6. Child malnutrition rates are high, with 10 to 15 being underweight for age and more than 1 in every 4th child being stunted, that is suffering from chronic malnutrition. These figures and the infant mortality rate have not improved over the past 10 years. With HIV/AIDS, the situation for health for children and mortality rate is deteriorating here like in the rest of South Africa. These children and their mothers make up Philani's target group, and the initial and still main function of the organization is to prevent malnutrition and identify and rehabilitate children who suffer from mild to moderate and severe malnutrition. Philani has 3 main programs and some support programs. The home-based nutrition intervention program is based on 2 international child health models adopted to South African circumstances. Jerry and Michelle Sternin, under the auspices of Save the Children, developed a successful national nutrition program for Vietnam in the early 90s, based on a positive deviant approach first described by Gretchen Berggren. Every poor community developed its own survival strategies or coping mechanisms. Some others, positive deviants, raise healthy children despite poverty. Community members in the Vietnam program identified these survival strategies, and interventions were developed in support of these locally developed strategies with some good results. David Oles has developed his nurse home visiting program in this country over many years, and through rigorous research proved its effectiveness in poor households. It stresses the important role of parents and of the child's early years, and argues that a good way of reaching parents of children at risk is to bring services to them. The result of his early research in New York State showed that the program helped to reduce childhood injuries and diminished child abuse. It helped mothers to defer further pregnancies and to have fewer arrests and convictions, to drink and smoke less and have fewer sex partners. His program has influenced child health and welfare policy in this country and is now operating in more than 20 states. Philani's 70 outreach workers are positive deviant mothers who are fulfilling the function of David Oles' home visiting nurses within the Philani home-based nutrition rehabilitation program. In addition to their coping skills, they have had basic training in, among other things, child health, nutrition, and HIV counseling. They do home visits and identify underweight children through growth monitoring and weight plotting. Although this nutrition conceptual framework might make little sense to the outreach workers, the program that they represent covers the underlying causes: food security, caring, and health. They address food security by making sure that mothers access the child support grant and any other grants that she might qualify for. Mothers on this program are also invited to participate in Philani's support programs and income-generating programs. They address care through education, social and emotional support, and sharing coping strategies, and health through encouraging immunization, TB and HIV screening, attending the medical checkups the program offers, including treatment of infections, diarrhea, disease, parasites, infestation, micronutrient supplementation, and referral for TB and AIDS treatment. Women's education, which underpins these underlying factors, is of course very much part of the intervention, and supervision and support an important condition for its success. These are two of our supervisors for the program. Severely malnourished children, or those not improving on the home-based programs, are referred to one of the 6 nutrition rehabilitation clinics for daily intensive rehabilitation. This child is 1 year, 10 months, weighing 4.3 kilograms, HIV positive and with TB, and the child was refused admission to the hospital in Cape Town. Children who participate in the daily rehabilitation program can also participate in a preschool. Mothers who bring their children for daily intensive nutrition rehabilitation are invited to learn to weave, to do beadwork or silkscreen printing, making it possible for young women to earn a living and become economically independent. It's important for them to have control over their own lives, and with that a bigger chance to protect themselves from HIV. We also know that when women have an income that they can control, it goes towards feeding the children. We regard the income-generating programs to be increasingly important in prevention of HIV/AIDS. The support programs now also include a house-building program initiated by a group of international students at the University of Cape Town. with the financial support of some Woodrow Wilson staff. They build houses, simple but effective structures for women who have been thrown out of their homes by husbands or parents, most often due to HIV. When we looked at the data from the Outreach program, collected with financial and technical support from the Center for Health and Wellbeing, almost half of the children admitted as and underweight for age were born with a low birth weight. Apart from the danger of a low birth weight, which increases the risk to die within the first year up to tenfold, and also has severe implications for chronic diseases later in life, a low birth weight child in a poor community often does not catch up, but continues to be malnourished. That information led to the Mother to Be program, where the outreach workers on their rounds invite pregnant mothers to participate in an intervention program, which has as its goal to improve birth outcomes. David Old showed that this program did not yield the same good results if run by paramedics instead of nurses. There is no way South Africa could run a program like this nationally with nurses. And our challenge is to choose and train women who will be effective, knowledgeable, and committed home visitors. Supervision and support is paramount. Preventing burnout and other issues as home visitors meet a level of illness and destitution in these communities that it is difficult to describe. There is a lot of movement which make it difficult to trace and follow up mothers and children. In the traditional African society, alcohol use by women was not acceptable, but in the urbanization process, alcohol is used more and more by young African women, and where the mother abuses alcohol, we have great difficulty rehabilitating the children. Another challenge is to effectively function as a support structure to government child health services. Although we are partly funded by government and have good support from top structures, outreach workers are at times not accepted by government clinics, staff as part of the health team at the local level. In the early years of the program, Whittaker from the Department of Community Health at the University of Cape Town traced the children who had been discharged from the Crossroads Philani clinic, fully rehabilitated from malnutrition, to evaluate how they managed once discharged back to the same poor community. Close to 70, and he published these results, close to 70% of the children they traced had maintained normal weight for age a year after discharge. He also did a cost-effectiveness study of their rehabilitation program, which compared favorably with what would have been the case these children had been admitted to hospital for rehabilitation. Between 45 and 60% of the children rehabilitated at the clinics have been fully rehabilitated within 6 months, and another 10 to 15% improved, which compares well with the 38% improvement in nutrition status of children attending a state rehabilitation program in Mitchell's Plain outside Cape Town. Close to 55% of children on the outreach program were fully rehabilitated within 8 months. And those who stayed on the program, 70 were fully rehabilitated within a year, without any food supplementation or handouts. One of the reasons why we have survived in fragile communities during turbulent political times is the fact that a great majority of the staff working for Philani and participating in management and decision-making structures come from the local community. This has created ownership and led to what we hope sustainable programs. Your strength can also become your weakness when decisions take long in committees, and the skills we need to grow and develop are not always available locally. Although the program started as a medical nutrition rehabilitation program, and there was no grand plan to become anything else, the organization has grown towards a comprehensive health and development program as a response to needs expressed by the community. We still have much work to do to properly evaluate the effectiveness of this approach. Thank you.
Thank you very much, Ingrid. We thought we would have all three presentations, and then we would have discussion to follow. So we're going to turn now to Professor Christina Paxson, who is the Hughes Rogers Professor of Economics and Public Affairs, and she's the founding director of the Center for Health and Wellbeing here. She's also the senior editor of The Future of Children. So, Ms. Paxson.
Let me just get, yeah, I can find it, I'm pretty sure. There we go. Okay. Good. So it's really nice to see everybody. I really like Philani. I'm gonna focus on sort of a broader picture of a larger type of set of programs. But like Ingrid, I'm going to be focusing on children's health and development. I wanted to talk a little bit about just the general relationship between economic status and children's health and development within poor countries, showing you data from one country where I've done a lot of work in Ecuador. And then switch and talk a little bit more broadly about different types of cash transfer programs and strategies that are being used to buffer and protect children's health, foster their development in different countries around the world. So, I think there are a lot of facts that we know really well, so I'm not going to spend a whole lot of time on them. But there's just an enormous amount of research that shows that even both across but also within countries, poor children have worse health outcomes. So within poor countries, poor children are more likely to die, they're more likely to be stunted and wasted. And then things like diarrhea and respiratory infections can impair growth and also lead to mortality. One thing that I've become increasingly interested in, because I'm interested in the long-run implications of children's health, is not just these physical health outcomes, but also cognitive and developmental outcomes that accompany poor health. And the evidence here, I think, is much more limited. If you look at wealthy countries, we have lots of evidence on children's development of language skills and memory and different types of cognitive function. And the data from poor countries are very much farther, few and far between. But they're show actually very similar things to what you see in rich countries. This is a graph that I really like from Ecuador, where I've done a lot of research. And this is shows children at different ages. And this is their percentiles on the TVIP score, which is the Spanish language version of the Peabody Picture Vocabulary Test, which is a very widely used test for children's vocabulary acquisition. And this is done using developed country style norms, which may not be appropriate, but it gives us some way to compare what's going on among a sample of poor children within Ecuador to a sort of general wealthier group of children. And the thing that I think is really interesting is when you look at children who are around age 36 months, this is a scale that in the U.S., the mean would be about 100, standard deviation of about 15. And at 36 months, these kids don't look very, very different from what you would see in the U.S. population. As you move through time, though, well, the best kind of these kids, the kids who are in the 90th percentile who are performing well, their scores really hang in there. They're doing better than U.S. averages. But what you see at the other end is this increasing dispersion. And even among a poor sample, the children who are not doing well in language acquisition, their scores are just plummeting. So at the 25th percentile, you have children who by age 72 months are performing at a level that very, very few children in the U.S. or in more developed countries would be functioning. So that we get children falling increasingly behind as they become older. One thing we did was we went back to Ecuador. Now, these are a lot of tests, and I'm not going to explain them all in detail, but I'll just tell you really briefly what they are. What they show are a set of measures of physical and cognitive development, again, in a sample of poor children in Ecuador, where we have outcomes families here, graphed against a measure of how wealthy families are here. And so up here, we have hemoglobin scores. The red lines are the 25th and 75th percentiles of expenditure, again, within a poor sample already. And we get what isn't that surprising, which is hemoglobin levels rise with expenditure, height rises with expenditure or wealth. But then we have a set of these cognitive outcomes, which actually follow very similar patterns, and in some cases are actually more pronounced. In this study, we looked at fine motor control. We looked at language acquisition, which I just showed you. This is a test of short-term memory. This is a test of long-term memory. This is a test of executive function, which is sort of cognitive processing speed you can think of. The only thing that really doesn't vary much across wealth groups within this poor sample are children's behavior problems. But what we see is that even among poor children, children who are at the bottom end of the spectrum are starting life at ages 4 to 7, before they've even reached school, a lot of them already doing significantly worse in a set of outcomes that are likely to affect their ability to function and earn and be productive adults when they get older. So this is a big problem. Now, Ingrid actually mentioned, Dr. Roux mentioned the different types of mechanisms that might lead to poor health and developmental outcomes in childhood. And one, which I think is, there's a lot of literature on it, is the role of nutrition in cognitive development. So these health and developmental outcomes are really likely to be very closely linked. So there's a lot of evidence that protein energy malnutrition is related to cognitive performance, iron deficiency. There's a lot of literature on micronutrients, which is more mixed. Some micronutrients, such as iodine, there's clear evidence that deficiencies can impair cognitive development. Now, healthcare may also matter, and it may matter in a couple different ways. One is that because a lot of healthcare centers, their role is to do nutritional monitoring, having access to good healthcare may draw attention to parents that children are not growing properly. They can be given supplements and monitored. Healthcare may also prevent illnesses such as diarrhea or respiratory infections that impair growth and cognitive development. And may also provide health information for mothers. Parenting is actually something that tends to get short shrift in a lot of the literature on health in developing countries. Although it's taken for granted, I think, in a lot of wealthier countries as being a really important determinant of children's development. Parents with higher incomes may be able to buy more stuff that's good for their kids' development. They need to be less stressed and less depressed. And they also may be able to spend more time with children or put them in higher quality child care arrangements. So for all of these reasons, we think that there are a lot of different reasons why economic status and health and development may be linked. So the really relevant question for us is, well, what kind of policies are going to work? If we try to think of kind of large-scale public programs that can improve health and developmental outcomes, what types of things do we want to consider? One type of program that's gaining in popularity is called conditional cash transfer programs. These are sort of spreading like wildfire throughout the world. And what they do is they combine basic poverty alleviation in the form of cash transfers to parents, combined with incentives to improve children's health and educational attainment. So, the standard program would say, well, if you're going to get money every month, if you're a poor family, if you qualify, you have to keep older children enrolled in school. Younger children have to be taken for regular visits to health clinics. Sometimes parental education is incorporated in the program. Money is typically given to mothers. Money is given to mothers, yes. So like I said, these conditional cash transfer programs, they started in Mexico. They're spreading like crazy. One thing to note here that I think is important, and we may come back to later, is that Mexico is probably the wealthiest country here, and as they spread countries that are significantly less wealthy than Mexico. Although now they're in New York City, so that's another example. Now, what do CCTs really want to do? I mean, if we want to look at how successful they are, we really want to look at the goals. And so I found actually there was a keynote address given by Ellen DeJongre from the World Bank at the 3rd Annual International Conference on CCTs. This is a good indicator of how widespread these are, if you could have a 3rd Annual International Conference. But But the keynote focuses on really 3 different goals. One is just immediate poverty alleviation. You want to get money in the hands of poor people. The second is to improve these investments in children's human capital. And then third, something that I want to come back later, that people usually talk in very vague terms about empowerment and accountability without what those things mean. That actually may be an important component. Most of the evaluations, however, have looked at the impacts of these types of programs on children's health, educational, and education. Here I'm going to focus on health outcomes. Just to give you a brief summary, I think part of the reason for the success or the spread of the DCTs was the very early evidence from the Mexican Progressive Program that that the program was effective in terms of both education, but also in terms of children's health. So there's some good work that's been done by Paul Gertler that looks, and Emmanuel Scufias at the World Bank, that looks at how households that got this program, the reductions in reports of children's illness, heights are improving, hemoglobin levels are improving. Unfortunately, the early assessments of this program didn't build in measures of developmental outcomes of kids, so we don't really know much about that. They were added later, but it's hard to really tell what's going on there. There have been some evaluations of some of the other programs, and the truth is, I think when you start to look across countries, the evidence starts to get a little bit more mixed. So, for example, in Nicaragua, there was a big increase in household expenditures, you would expect. Program. There was a huge increase in attendance at clinics. Kids were going to health clinics, but there wasn't an increase in vaccination rates. There was a big reduction in stunting and wasting, but there was no change in anemia despite the distribution of iron supplements, right? So we're left with sort of a mixed bag and an unclear picture. And I think, right now, with these programs spreading, a lot of the evaluations are delivering mixed pictures, and we don't really have a full assessment yet of how well these things. Now, one issue that comes up a lot is whether this conditionality, whether you have to say you have to do this in order to get the money, is really necessary for programs to be effective. And there's a lot of evidence that predates conditional cash transfer programs that says that putting money in the hands of poor families, if you do it in the right way, can actually result in improvement in children's health and development. There's some good evidence from South Africa. So there's work by Duflo that looks at old age pensions given to grandmothers that tend to improve the health of their granddaughters. And Case has done work on child grants that again show beneficial effects on children. You can correct me if I'm getting you wrong. But not the benefits tend to be focused more on children who live with their biological which is an issue in South Africa. Now, I've been doing work on this program in Ecuador that was supposed to be a conditional cash transfer program, only the government got into a fight with the banking system, and it never turned into a conditional cash transfer program. It's just a cash transfer program. So we have this an example of a program where we can look and say, what happened when cash was delivered to these poor families with children. Like a lot of the other evaluations, we incorporated a randomized evaluation as part of this. So some families got the program early, some families got the program late. They were randomly allocated to those two groups. We can compare them and see whether the early receivers of the program did better than the late receivers. Now, one thing is this is a small program. At least when it started, families were only getting $15 a month. That's since been doubled. But at the time of our evaluation, it was pretty small. So we have 6 provinces in Ecuador where we did the evaluation. Basically, we're following households for 18 months of exposure to the program on average. So, we conducted a baseline survey, the program rolls, we go back and do a follow-up survey. We're about to start a second round. And we collected a lot of information on kids' outcomes. Now, this is one thing that's actually really important that few people show in their evaluations, which is making sure that programs actually the money actually gets in the hands of the people who it's supposed to get to is actually pretty important. And so we did a really careful job looking at banking records, making sure that people in the treatment group got the money, people in the control group didn't get the money. I think tracking this through time will be important to make sure that eligible and non-eligible people are kept separate. The results for children's outcomes, the treatment effects. These are a lot of numbers, but let me just explain in words what they are. Basically, what this shows is the difference between a treatment and control child expressed in the deviation unit. So the way that you would say this is, look at this is, on average, a child in the treatment group had a score on a long-term memory test that was about 20% of a standard deviation bigger than a child in the control group. That's a pretty big effect. But when you look overall, you know, most of the effects are positive. They're not huge. A lot of them aren't statistically significant. We weren't that surprised by that because it's a small transfer program, and when we first went back, it hadn't been running long. Now, the thing that I think surprised us more was that when we looked at the very poorest children in our sample, and this is children in the bottom quintile, the effect sizes look much bigger. So there are actually big improvements in hemoglobin and fine motor control and long-term memory and visual integration function and even in behavioral problems. So just to give you a sense of when you aggregate these, what they sort of add up to, basically they're adding to about a quarter of a standard deviation increase in improvement on these measures. Effect sizes for the poorest children are 17 percentage points less likely to be anemic. They do a test of fine motor control faster. They have increases in short-term memory that are equivalent to a fairly sizable increase in percentiles based on published norms. So the early results look pretty promising. Now, one thing that you could think is, well, okay, children are healthier, so it must be that they're using more healthcare services. And the thing that's kind of interesting in Ecuador is that they're not, right? This is really the measure of healthcare services, whether the child have what they call a growth control visit in the last 6 months. That's a visit to the clinic near them. And the treatment kids are no more likely than the control group kids to have been to a health clinic. They're more likely to have parasite treatments, which is actually interesting because that's consistent with the reduction in anemia. And there's also some evidence that their mother's hemoglobin levels are going up here significantly, which is consistent with family nutritional standards going up. Now, the last thing I want to show you from this, and then I'll conclude because lots of general implications, is these blue lines are the pictures I showed you before, right? Of the relationship between these outputs and expenditure for the control. The red lines are the same thing for the treatment group, the kids in the treatment group. And so what you can see here, for example, is on the TVIP score, what it basically did was lift up the scores for the poorest kids. The same with the memory test. In some sense, these results are too big to be believed, right? They're too big that they're larger than what you would expect if you had just given households $1. Basically, you're seeing, for some of these measures, almost an eradication of differences between the poor and richer kids. So one thing that we sort of think about is, well, was it something about the way this program was structured that had larger effects than you might have expected of it? Like a lot of programs, it was targeted to mothers. Mothers had control of money. That could have been important. It was also advertised as a program to benefit children. And that sort of social marketing may have influenced the way the money was spent. After going through this whole exercise, I decided that this idea of, should we make things conditional or not conditional, really isn't the issue. The issue is how we can structure programs in ways that are sometimes subtle that influences how resources are used and how they affect children. I wanted to come back to this idea of empowerment and accountability, which is one of these very vaguely stated goals of conditional cash transfer programs. And this may be one area where the conditionality matters. I think actually when people talk about empowerment and accountability, they're usually talking about empowerment of women because money is given to women. And they're also talking about the accountability of parents because parents have to be accountable in order to get their transfers. They have to do things. But you could turn this around and think that the advantage of a conditional cash transfer program is that it may force some accountability not on parents but on the public sector that's providing the health and education services that people have to use in order to get access to their cash. And this is something we don't really know yet. We don't know whether in countries that have implemented conditional cash transfer programs, people are a little bit more empowered to say, look, you say that I'm supposed to bring my child to a healthcare clinic. Well, the clinic better be able to provide services that are actually good for my child. And I think that's a really interesting thing that we have to look at. One thing that I'm concerned about, and maybe we can come back to this later too in the discussion, is the long-term viability of means-tested programs. I think Ecuador is a good case in point. The country did a very careful kind of census of households to decide who was and wasn't eligible. And they did it before the change in the program had been announced. So households really didn't know why this was being done. They're going back actually in November and starting to do another second sweep of means testing to decide who should be kept on the rolls, who should be thrown off the rolls, and who should be added. And now people know that when these people come to the house with a clipboard, that they're actually there to make some assessment that's going to govern whether or not they're eligible. So it'll be really interesting to see how the means testing changes as we go on. I think that's all I had. So hopefully those will be a good work for the presentation.
Thank you very much, Chris. Our last speaker is Professor Angus Deaton, who's the Dwight D. Eisenhower Professor of International Affairs and Professor of Economics at Princeton, who's written widely on determinants of health in both poor and rich countries. I'm sure we can.
You shut me down.
Okay, so
There, it's back together.
Yeah, and then it's, where are you? Which one are you? Middle one?
Yeah. That looks like me.
And we'll put you up.
Thank you. Thank you very much. And I think I will probably be relatively brief, or I hope so. So we've heard the wonderful story of this splendid program in Philani, and we've heard Chris talk about conditional cash transfer programs in Ecuador. I want to elevate it even further. I don't mean elevate the tone of the discussion, but elevate the point of view and move really from the ground up into the sky and talk about some of the general issues that arise in thinking about global health for children and for poor people around the world. When you see, I think if you come to it like you've heard today, one of the things that seems odd about a lot of this discussion is that you hear about a program like Philani or lots of other programs that many of us have been involved in, and you think, what a great program. We need to do this lots of other places. And there's lots of stuff like that around the world, which really seems to work on an individual level. This parallels our own day-to-day experience, which is if so a neighbor or a friend or someone who lives nearby is in distress, you can help them. And we know we have that ability to help people who are in distress. Yet when you pull the whole thing together and look at the world as a whole, it sometimes seems like we're not making as much progress as you would expect, given the degree of commitment there is out there by people, by countries, and by international organizations. More than 1 billion people still live in absolute poverty after a very long time of trying to do something about that. Millions of people have poor health and die too young. Let me show you some of these numbers just to document these failures. Ingrid already talked about the 10 million children who die every year, and those are deaths that would not take place if those children had been born in rich countries. So they're preventable in that sense. I mean, there's nothing that we need to know that we don't know about saving those lives. There are 25 to 28 million people in Africa who are infected with HIV/AIDS, and over 2 million die every year. Few of those are still receiving ARV therapy. And once again, those are people who, if they'd been infected in rich countries, would not be dying in anything like the numbers because they would be on antiretroviral therapy. Another fact that many people know is that life expectancy has fallen very rapidly in sub-Saharan Africa over the last decade or so, and has undone much, and in some countries all of the progress of the last 50 years. So that one of the great triumphs of the second half of the 20th century was the elevation of life expectancies around the world, including even some of the countries in Africa where not much else has gone right. And many of those gains have been offset, so we're now back to life expectancy figures that prevailed not long after World War II. Of course, a lot of that is HIV/AIDS, just in another form. And yet at the same time, just by contrast, and keep reminding you about these inequalities, we're doing great here, thank you very much. The life expectancy still continues to rise, mostly through improvements in the treatment and prevention of cardiovascular disease, some of which are extremely expensive, and also from reductions in smoking, especially for men. I mean, women have been lagging quite a long way behind there, and mortality rates for women are only now beginning to fall in the richest countries, and in quite a few rich countries not yet. But nevertheless, there are these gains in the rich countries, so not only this is the time when these people are, if you like, needlessly dying because they wouldn't die here, and at the same time in the rich countries, we're getting even further ahead. So these inequalities in some way are actually expanding around the world. This is a table that comes from a paper that Adriana Yarasmuni, David Cutler, and I wrote a few years ago. And this also illustrates some of the main points. So the numbers here are in millions of deaths. So this is like all the deaths in the world. These numbers can't be taken too seriously. They come from the WHO, so we didn't make them up. But you shouldn't take any particular number too seriously. But the general picture here, I'm pretty sure, is right. So then what you've got on the left-hand side here is a list of diseases that are killing people. The second column gives you the treatments or means of prevention that exist for dealing with those conditions. And then the next column gives you the total number of deaths in the world. And then the next two are for the World Bank categories of low-income countries in the world and for high-income countries. These do not divide the world. There's middle income, which are not shown. So you can't add the two together to get the first column. So if you look at this top half of this table first, you'll see the first thing is that if you compare the low income and high income, there's essentially nothing down that last column. So these millions of people, millions of deaths that are taking place in the world are nearly all taking place in low-income countries. And if the only one that's a slight exception is respiratory infections, which you can see here, 0.34, and that's because a lot of old people in rich countries die of pneumonia. But if you take that apart, these respiratory infections kill people in poor countries. HIV/AIDS deaths are nearly now all in low-income countries. Perinatal deaths, diarrheal disease, TB, malaria, and the vaccine diseases that are in rich countries, we now prevent by the routine vaccination of children. These are not costly things to do. I mean, these vaccines cost pennies per child. We know how to do it. We're not waiting for a huge technological breakthrough, which you might say in the case of HIV/AIDS is, but apart from HIV/AIDS, we sort of know how to treat these things. They're not very costly. We've known how to treat them for a very long time, and yet large numbers of people die from them. The other thing is in the last two rows of this table, you can see that of all these deaths, the world, they're mostly, half of them are at ages 60 plus, and 18% are at ages 0 to 4. But in the low-income countries, these are about equal. So the deaths are happening in the first few years of life, or in fact, the first few years of life become the last few years of life. And again, at the opposite, whereas you go to the rich countries, there's essentially no kids, not no kids. We worry a lot about infant mortality in the U.S., but in the rich countries, it's a tiny number compared with the numbers in the poor countries. So not only is the diseases different, it's the age structure. We're really talking about the deaths of children. And essentially, in some sense, unnecessary, or at least they're unnecessary in the sense that we know how to stop them in a technical medical sense. Of course, knowing how to stop them in an economic sense or a social sense or a policy sense is really the hard question. So the question is why? Why is this bad stuff happening in a world in which there's really no need for it to happen? The World Bank, WHO, UNICEF, and other agencies have been working on poverty and international health at least since World War II. Large sums of money in aid, especially for poverty reduction, and more recently, dedicated global funds for health. The Gates Foundation is spending lots of money on health, the Millennium Challenge Account, and so on. They list these. Are we actually making progress? You know, you could say, I suppose, that we didn't really focus on health very much until relatively recently. Now we're doing it right. I don't think that's really quite true, but, you know, are we making progress, and how should we spend the money? And how do we do the counting? Well, one line of thought, which is worth considering, and actually Chris's presentation is an excellent introduction to this, which is, Chris showed you, and you can do this for many, many countries around the world, that poorer people do worse than richer people. And it's also true that, obviously, you've seen from the previous graph that richer countries do better than poorer countries. You can also trace this through history. As we got richer historically, we've gotten much less likely to die. We live longer. So maybe it's really money. And that's some of the theory behind conditional cash transfers or unconditional cash transfers, that maybe keep giving people money will do this. And then there's a line that goes from this which says, look, we can let countries look after their own healthcare systems. It's not that's the constraint. We know what to do. They're sick because they're poor. So what you need is not healthcare, it's economic growth. So the question is, can we fix, this is the wealthier is healthier hypothesis, that we don't really need to do health interventions around the world. We should close down WHO and give the World Bank more money. Of course, the World Bank is pretending to be WHO these days, but you give maybe to the International Monetary Fund or something, and you grow these countries faster. Now, I mean, I've worked on this quite a bit over the last few years, and I think it's a very plausible story, but I think it's not true. And in fact, if you look country by country and you look at growth episodes and what's actually happened to mortality, you just can't get them to match up very well. China is the classic, but certainly not the only example. And, you know, most health improvements in China took place before economic growth really picked up. And then when economic growth really picked up, the health improvements sort of stopped. The India story is less dramatic, but it's somewhat similar. And you do this country by country, and you just can't match up. Even over long periods. It's not just like 1 year of growth doesn't produce health. It's even 10 or 20 or 30 years of growth sometimes doesn't produce health. Now, my guess is that what's really going on in these data is that growth and health improvement are likely related to government capacity. So that if you've got good governance, good institutions in a country, you're likely to get good health improvement or good health level and good economic growth, because they're the preconditions for both. But you also need the government to actually be interested in doing something. So if the Chinese government suddenly decides it's not very interested in public health anymore and it wants to grow, then that's not really going to be very good for health. That also leads us to some other things. These are really like bylines, which is if you've got a government that's not capable of providing health, the private sector is not likely to be much of a substitute either, because the government, you can't have private health care without good regulation of some sort. And if the government can't provide it, it probably can't regulate it either. And that's a very good example of what's happened in India over the last few years, where you've just got a disaster on both fronts here. So what to do? So here's the other line of thought. Let's say it's not economic growth, but we think we actually have to do something, and maybe we can do something. So what should we do on the health front? So this is the sort of topic of this symposium. So we need to know what works and why. Now you might say, hey, the World Bank's been spending all this money over the last 50 years, doing all these projects, it's got infinite experience in these things. Surely by now it knows what works and what doesn't. Well, it doesn't. And the reason it doesn't is because it really hasn't tried very hard to learn from what it does. And I could talk about that for a very long time. I don't think it's their fault. I think it's to do with the way that the World Bank is set up, that it's just not well suited to learning from experience in that way. The accountability structures in the World Bank, I don't think are really capable of delivering serious evaluation. That might change. So serious in this case means that there's some reasonable counterfactual. So you can, you don't just come home and say, I like my program, we did wonderful things, it's great. Well, did you have any counterfactuals? Well, not exactly, etc. And that's what the World Bank's been doing all these years, and that's why we don't know. Now, one important line of thought, and this is a major thrust in development economics today, which is to do experiments, is actually to do essentially randomized controlled trials of various projects, especially service delivery projects, many of them in health, also in education, to try and find out what actually works. The Poverty Action Lab at MIT, now called JPAL, after their main donor, has been doing sterling work in this direction, and they have people doing this all over the world. The World Bank, like many of these things, has gone from total resistance to total capitulation towards randomized controlled trials, and now they're doing all sorts of randomized controlled trials, and they have a program called DIME, the last word of which is evaluation. I forget what the other words are. And the hope here is if you do these experiments, you'll actually learn what works. Then we can design aid with the hope of making it work. And we can, instead of groping around in the dark doing things that sometimes work and sometimes don't work, we can actually do a little better than that. So I think there's a good chance that we'll find out, not necessarily what works, but whether randomized controlled experiments can tell us what works or not. And this, I think, is an enormous service by JPAL and their friends, which is 5 or 10 years from now, and they're doing such an enormous amount of work, we'll get a good idea whether this is the program for learning that we need. And I think the World Bank tipping over to this and randomizing everything in sight is not a tremendously good idea, but it's probably better than what they were doing before. But it's like a lot of these public policy things, they behave badly in one direction, and then you wish they'd never listened to what you've been saying all along. Here are some of the strengths and weaknesses, and then I'll stop. The strengths are obviously what it's designed to do. They give you good counterfactuals because you have randomization. So the experimentals and controls are genuinely randomized. So you get serious evaluations of actual programs, and you got a pretty fair chance at the end of that program of knowing whether the good things or bad things that happened were a result of the program or were a result of something else. They're wonderfully good for debunking things that are not true. I mean, a randomized experiment is a great way of constructing a counterexample, because if someone makes a genuine claim, like it's always better to give money to women than to men, you can go and do an experiment like Esther Duflo did in India, and you can find out that, women do what they're interested in and men do what they're interested in. You may approve, you may disapprove, but there's no general blanket thing. So I think we learn on things like that. Whether we learn what to do is a much harder thing. The other thing that these things do is they often show you that problems that you didn't know about will actually come up. And you can see it on the ground when you're doing the experiment that something you thought would work doesn't work. And that's a very good sort of trial. What are the weaknesses? I think perhaps the biggest weakness is the external validity problem, which comes from what I think of as heterogeneity. I mean, the effect of this program is different in different settings. So even if you randomize, say, across Indian villages, you give half of them some sort of school and the other half don't get the school. It's not clear that when you take that program to Ecuadorian villages, for instance, you'll actually get the same result. And it's actually quite often clear that you won't, and that there's no particular reason to expect. So you get this sort of internal validity, but it doesn't necessarily extend beyond that. In general, there's no reason to suppose that works in one place will work elsewhere. Now, people say, well, we have these very successful randomized controlled trials in medicine. The FDA does them all the time. Why doesn't that work here? I think to some extent that's a misunderstanding, that RCTs are part of a regulatory and licensing process for the FDA. They're not really part of the basic science, or at least they're the final stage of the basic science. Much of the basic science having been done prior to this final regulatory improvement, which is going through the FDA. The other thing that's the case is there's scaling up issues, as there are with seeds, for instance. The Agricultural Research Station gets great returns on these things, but when you actually hand them out to farmers, they don't work as well. That's some of it. In other cases, there are macroeconomic effects from scaling up. So you can do it on a small scale. You put a lot of money into a small thing. You get dedicated people. It really works. You try to do it in the whole country, and then it's really hard to get the same quality staff. There's not a lot of money around, so that corrupt officials are much more attracted to come and get it. And there's no guarantee that what works in little things will work in big things. The last thing which is very important about experiments is when they fail or when they work, you don't actually know why. And you'll find this all the time. One of the things we've learned from listening to people reporting these experiments is that they're making up stories about why it worked or didn't work. And they don't have any evidence for those stories at all. So then they say, well, we have to do another experiment. Well, when you think about that, it's a very, very slow way of learning. So what do you need? What we need is theory. And, you know, I think we've lost sight of this in economics to some extent, but it's not just economics. What I put here is incentives, is theories about the biology, is theories about behavior. And what we should be doing is doing experiments that not test service delivery systems or something. I mean, that's the final stage. What we should be testing is some notion of how these things work, some model of how they work, because it's theories. Theories are about generalizability. You know, if a theory has some theoretical foundation, it's something that does carry to other situations. And I think without that, we're not really going to go anywhere. And that's one of the things the main reason why I'm somewhat skeptical about the program as it goes right now. Let me finish with the other side of the coin, which is what I call a less hopeful picture. There's this argument, which has gained a tremendous amount of traction recently, is that aid doesn't work because it's basically impossible to work from outside other people's countries. The people have to develop their own countries. The rich countries got that way by themselves, not with external aid. And external aid is as likely to do harm as it is to do good. I think of this as the Bauer-Easterly view. Easterly is the current champion of this view. Lord Peter Bauer, for many years, argued very, very similar things in development economics, say 50 years ago or so. And in fact, I think that some people will argue this question of whether aid works or not is a question that really can't be answered. But I think to the extent that it can be answered, it's been answered pretty much in the negative. Not that it harms, but that just there's as much evidence one way as the other when you pull this stuff together. And I think the very best studies are the ones that really don't find anything where you would expect to find something. So that's mostly aid for poverty reduction, aid for growth. And the question here, and I think this is maybe what brings many of us here, and certainly motivates me, is that we think health might be an exception. That giving foreign aid to make a country grow may be a completely lost battle, but it may be that health is not like that, and that we really can help bring the gift of health to the people I started with. Well, I think to some extent the answer to that is yes. And it's clear that basic science, and one of the examples I like to give is the discovery of the HIV virus. That would not have been discovered in sub-Saharan Africa left to itself. So that is a gift, as it were, that it's an aid that really did work, that the virus was discovered, understanding the mechanisms, that scientific knowledge is now available for countries to use as they wish to help improve the health of their people. Another example is the invention or the discovery of oral rehydration therapy. This is a discovery within the third world that spread from Bangladesh and other places to other countries, and has saved a very large number of children over a period of time. So these basic science things can certainly be moved from one country to the other. What about the other stuff? Well, that's, I think, where the jury is still out. I think the record on the ground of external health efforts is not always good. One of the things that Ingrid emphasized in her talk, and which I think is really key, is that this is a largely indigenous, locally owned program, which has largely come from within the community. It's not come from outside. There are stories over and over again about the bad things that happen when people come from the outside with large amounts of money. Some of you will know the story about slim AIDS and fat AIDS. Slim AIDS are the local people who are dying of AIDS. Fat AIDS are the health workers, the aid workers from foreign countries who are living on the proceeds of the money that's coming in. Helen Epstein's book has some wonderful examples of the good things and the bad things, and how many of the bad things that come from outside undercut some of the indigenous things that look like they might actually have some chance of working. There's, of course, as many as you will know, a long, endless, unresolved, and very bitter debate on vertical versus horizontal health interventions, and this whole issue of whether vertically directed schemes, such as the WHO's international campaign to eradicate polio, for instance, leave the local health sectors actually worse than they were before. There's accumulating evidence of this in India now, where the campaign to eradicate polio has detectable effects, maybe they're worth it, but still effects, on lowering vaccination rates among children who would otherwise have been vaccinated if all these nurses and health professionals had not been out hunting down the last polio cases, which are very resistant to being hunted down. So I don't really have anything more to say. I have an open mind on this. I'm pretty much persuaded that financial aid doesn't do much to aid growth. I'm much less persuaded that we know that we can't do anything in health, and I hope very much that we can. Thank you very much.
So thank you very much, Angus. I'm going to ask our panelists to please come and sit up in the front, and they're all happy to take questions. So.
Thanks. Question for Mr. Deaton. If you think that randomized experiments should be focusing more on theory, in what ways can theory incorporate regional differentiation that is kind of dogging transportability of programs?
Do you want me to answer one at a time, or do you want to collect some questions?
Answer. Yeah.
Okay. Well, I mean, in some sense, I'm saying it can. I mean, we've got to find something that transcends. I mean, if by regional you mean African versus Latin American or something, I'd be happy for a theory that works within Africa, right? But if by regional you mean local, then I think we're in much deeper problems, and I don't know. What troubles me in some sense is that so much of this movement is not thinking about that issue. It's just going out randomizing everything they can get their hands on. And I think that, you know, it's like doing experiments in the lab, and you say, what are you doing experiments on? They say, well, we find some dishes, and, you know, there's some chemicals here, and we poured these together. And they say, well, what do you hope to learn? They say, well, these are really neat experiments. And, you know, here's the experiment, here's the control, here's the answer. But, you know, without some idea of why you're doing this, it's not entirely clear.
Yes.
Yeah, I was wondering if you could give some examples of how one specifically tests theory.
I'm not sure I have good examples. I mean, it's, you know, I mean, the closest I can get to is the counterfactual. I gave the counterexample. You know, you have a theory, general theory, in this case, that, you know, randomized, that putting, the experiment in India was that if you forced the panchayats, local councils, to have women representatives on them, this would make things better. So that was a theory. Turned out not to be true, or not true in any very simple way. And so, but it's much easier to set those up in positive, in negative ways like that, than it is to actually decide sort of what works. And maybe that's the way you have to go.
I have a question for Ingrid, actually, which is one of the things that Angus mentioned is about the fact that there are examples of things that seem to work at the local level, right? And I wondered if you could talk a little bit about difficulties in, like, scaling up, since I know that Philani over time has gone to being bigger and bigger, and I wonder if you think there are, you know, upper bounds on how large it could be and why there might be such bounds.
You know, I think the whole issue about scaling up in South Africa is management. And we lack management capacity on a local level and on a national level. I think when you scale up, you have to have very simple solutions to problems. You cannot have complicated solutions. And I think the outreach program, I believe in intervention at the household level when you look at the very micro situation. And to scale up the outreach program, you need to have very good supervision and management structures. And I don't know if we have that in South Africa today.
My question is a little bit of a different aspect, but maybe it's a conditional cash transfer theory.
focus is given to the educational policy?
The
Educational policy.
Oh, I mean, I think a lot of the programs that are out there, the education is a big part of the programs. A lot of the evaluations have focused on the effects of the programs on educational attainment. And, you know, it's not that surprising that if you say you'll give money to people if their kids go to school, their kids are more likely to go to school. I think the health issues are a little bit more interesting because we're not really interested in having children go to health clinics for the sake of going to health clinics. We want them to become healthier. So I didn't focus on those in my talk, but there is a lot of work out there on educational attainment in the CCTs.
No, I think the last issue you closed with is something that has inspired a lot of us to think about schools too, which is that it might help parents put pressure on schools where there's enormous amount of absenteeism, teachers not showing up to work and so on, which is also true in clinics, that it depends how they're designed, of course. So if all you have to do is show up there, but some of these schemes, the teachers would be required to be there, the clinics required to be there to stamp the cards, and that might be good. I mean, after decades of pouring money into health systems and schools, with very little to show for it, at least in some countries. And I mean, I work a great deal in India, and I know that, Jeff Sachs tells me all the time that, they're not spending enough on health in India, and I'm sure that's right. But if you put more money into the system as it is now, you're just in complete disaster. So, the money that's being stolen, just more of it would be stolen, more people would not show up to work. So one of the possibilities of these schemes is that you can actually, the parents then begin to monitor the providers and have a greater stake in monitoring the providers. And in some states in India, like Himachal Pradesh, you went this switch from sort of apathy among the parents to a much more organized and concerned set of parents who were, really monitoring the schools. And if you could go from the bad equilibrium to the good equilibrium, that would really help, and maybe these will. There's stories about Kerala that Jack Caldwell tells in the 60s about the health post being closed. Well, where we work in Rajasthan, health posts are closed most of the time. And this health post is closed in Kerala, and the people grumble, but on the first day they just put up with it. They come back the second day and still closed, and they go burn down the district collector's house. And the clinics in Kerala ain't closed. And, so somehow you've got to get people to realize that this is their right and this is a possibility for them. And this might help do this, but I don't know.
But we don't know whether that's true yet. And I think
no, it's got to be a leading hypothesis.
Absolutely.
Right, but we don't know. That's right.
Yeah.
And I can't agree with that in the South African situation. I mean, the quality of care that is available at community centers in the peri-urban areas is so poor, and it will not improve until people actually demand good care.
So how do we teach them to demand good care? I mean, how does that come about?
I think it has to do with confidence and self-worth. If you do not believe that you are worth good care, you will not claim it. So how do we improve confidence, and how do we improve self-worth? That's a big issue.
Right.
Yes.
I wonder if someone would comment on something that struck me as I was watching the pictures, the slides being shown of the individuals working, that so many of the adults were overweight.
Yes, that is the situation in South Africa as in many other poor countries, that there is overweight, obesity, parallel with malnutrition, and especially obesity in women. And in South Africa, there are 5 times more really obese women than men. And diabetes, the illnesses of the chronic diseases are just taking off in this area. And diabetes, hypertension, for example, especially with women. And why?
We've actually, Ingrid was kind enough to let us use Philani as a platform to actually run data collections, panel data collections, so we're following the same people through time. So the first time we went to these 500 households, we saw that over half the women were physically obese, had a body mass index above 30. So with Ingrid, we actually brainstormed about what possible reasons there might be, since you would think that a lot of the mechanisms, if it affects women, should affect men as well. Cheap calories, right? That's one thing you hear a lot about. Fast foods, cheap calories. But one of the theories was that possibly because they're malnourished as children, it may have differential effects on girls and boys. And there's actually studies with rats with sex-specific steroids, neuropeptides, that when girls in utero and in infancy are lacking those, actually it flips a switch and they're unable to regulate appetite. It doesn't have the same effect on the male rats. And so actually we went back, the second time we went to all these households, we asked a series of questions about what was true in the household we were raised in. About a third of both men and women reported having been very poor as children. But the women who had been poor, very poor as children, were significantly more likely to be obese. Not true for the men. So we think that connection between malnutrition and obesity is very deep. And we're just, beginning to scratch the surface of it.
And it's quite common around the world. I mean, the same is true in Egypt, the same is true in some countries in Latin America. It's beginning to be true in India. And it's really hard to believe that this explosion in obesity is not connected with those people having often been quite malnourished when they're children. When I was a kid in Scotland, which had a per capita income then that was less than twice what India's is today, which is sometimes I find hard to believe, then you had a very similar epidemic, which is, all my moms, all the other moms were huge. And, their moms had not been huge, and their daughters were not so huge either, but you got this one generation that has come out of poverty, and there was a lot of availability of carbohydrates and fats that hadn't been around, and they'd been quite malnourished as kids, possibly, and you get this real explosion. For one generation, one hopes. Maybe not.
Let's start here and then we'll work across, yeah.
This is a question for how would you characterize the role of NGOs, especially in sub-Saharan Africa?
Who are we talking to?
You.
Or
Any of them. Well, I mean, Philani is an NGO. I mean, they're so heterogeneous, it's not entirely clear. NGOs have been willing, and many of the JPAL experiments are done through NGOs, and NGOs have become more and more concerned with trying to figure out whether they're doing actually works, and that's certainly very welcome. It's hard to generalize about NGOs, though. There's a lot of different things you can say.
So I just want to go back to your thing you were saying about testing theory, but good policy is not good unless it can actually be implemented.
Right.
So how do you reconcile those different and you can explain a little more?
I don't mean theory in that very abstract sense, that it means it doesn't work in practice. I mean, it's just that, you have to think about what might work. So, for instance, this story that Chris was telling, which I'm very attracted by, and I don't know whether it's true, that this would incentivize the parents to demand better services. And you could tell a nice piece of economics about that. It's also something that hopefully would generalize. So it qualifies as theory, right? And it's quite practical, and we'd like to know whether it works. I'm worried also there's another theoretical thing that's really missing. These conditional cash transfers. For those of you who've taken the basic economics course here, you'll know that the conditional bit, according to basic economic theory, actually makes people worse off. It would be much better to just give them the money, right? And yet, when we as economists say that, people look at us like we're nuts. You say that to the doctors, and they say, "What are you talking about? We're only giving them money so they go to the clinics. You want to give them money and they don't have to go to the clinics? I mean, what sort of insanity are you as an economist?" But no one's come up with a coherent story of why these things work, even though they've done the randomized controlled trials. So we have the randomized controlled trials from Mexico and elsewhere, which seem to show that it had some good outcomes, but no one has a clue why. And my guess is that because no one really has a clue why, you're going to get the results that Chris was showing, which is that you're going to get weird results, different things in different places, and sooner or later we're going to have to step back and try to figure out what's actually going on here.
Yeah. There's another hand. Yes, Marco.
About the differential in obesity between men and women, do we see anything similar in developed countries? Or?
Yes, actually in the U.S., rates of obesity of African Americans is different by sex as well. More women than men. Actually, if you go to the WHO homepage, I could send you the link. In 92 of 110 countries where they have estimates of BMIs for men and women, in that many countries, the rates are higher for women than for men. The only ones that are the exceptions are sort of Western European countries. Yes?
I want to go back to the obesity and the nutrition. Do the women feel that it is a problem in South Africa or anywhere? Because what might work somewhere else, as I say, it's not necessarily that it will be the same thing. Because if I take the social theory, for instance, what is beauty to African men is not necessarily the beauty to a Western man. So while people might think that is a problem and beauty and so on, it might be it is sort of the social relationship between man and woman. What men consider beauty, so they encourage that, and so so my question was, are the women feeling this is a real problem?
That's a really good question. In fact, when we went back the second time, when we were asking a lot of questions about their diets and about what was true when they were children, we also showed them sets of pictures from very, very thin women up to very, very large women. We did the same for men. Our field workers loved this. They thought that was really terrific. They really liked this, and they wanted to find themselves as well. So people think, well, what is the ideal? People tend to think this is from 1 to 8. They think a 4 is just about right. But then larger women, we say, where do you see yourself today on this? Larger women saw themselves as being bigger, but the ideal woman saw herself as being equal to her perception of herself at that point in time, exactly at the point of obesity, at BMI of 30. So if you had a body mass index lower than 30, you thought you wanted to be bigger. And if you had a BMI above 30, you wanted to be a little bit smaller. Now, the only problem with that is, unfortunately, the fact that they're very comfortable with the way they look doesn't protect them against diabetes, cardiovascular disease, stroke. I mean, so it may be the case, though, it may be the case that perception may be changing. We have the latest round of data that we collected suggests that the younger women saw the ideal hit their perception of themselves at a body mass index of about 25, which is the cutoff for overweight. The older women at 30, which is obese. Now, so it's time will tell.
Yeah. Actually, there's something that is changing. If you take the beauty contest that is almost everywhere in Africa, if you take from 1970s to now, the way beauty was being looked in the beauty contest, it's not the same now. Where from the slim age and fat age, if somebody came from Europe or America for that matter to Africa and you're kind of slim, they wouldn't believe that you're coming from America or because to most of us in Africa, I come from Tanzania. So to most of us, when you come from outside, you have to be big because that tells you that you have been eating well, you have been having a good life. So when you go back and you are not that kind of things, those come from. But it's changing now, and the beauty contest, the girls are getting thinner and thinner. That's kind of beauty, which I don't know.
We'll take one more question, and then I think we're going to Senator.
I've got a question that really kind of links all three. And right now, for the bottom billion, the problem with clean water is big. It's big for local communities where most of the NGOs focus on sanitation, latrine, digging a well. Huge girls, women's issue, because the other ones are walking 6 hours to get the water. From a public health standpoint, the diarrhea directly or indirectly, it's because 1.3 billion people don't have access to clean water. And then, Professor Deaton, earlier in your slide, you said government to play a role has got to play a role. And quickly that spills down into whether there's ongoing conflict, rebellion, transparency, accountability, government itself. And then talking about bribing people, basically giving cash, which very poor just to have resources, and then the conditionality to it. You put all that together and then ratchet it up to the government itself. And historically in our country, our foreign aid has been very much sort of a cash payment, maybe not for good intentions at times, but a cash payment. And more recently, we had this experiment, not a trial going on, with the Millennium Challenge account that very much links to 14 countries so far, 16 countries, cash payments with conditionality of what? And the what? The rest part, what you can be. Right now, to date, it's been roads, infrastructure, not ARVs, not health. It really hasn't been very much health. But the sort of things that could impact health, on which clean water could be one. And that's a conditionality that means, government, you're going to get the funds if you have a roadmap there that obviously involves transparency, accountability, good governance, rejection of terrorism, and that you're actually doing it on the ground. That's kind of an experiment, though we've never done that historically. But if we were to do that, it all of a sudden begins to tie it together. And is it working? Do we have any experience that it's working? Is it too early to know? This sort of new idea of a Millennium Challenge account or Millennium Challenge Corporation?
I think it's probably too early to tell, is the answer. I'm a little skeptical. I mean, conditionality has been tried in lots of different ways before. And I think there are good theoretical grounds for thinking that it's very hard to make governments do things that they wouldn't do by themselves. I mean, ultimately, you need a government that has some form of contract with its people in order to make this thing work. And if that doesn't exist, whether you can engineer it from the outside, I'm deeply skeptical. On the other hand, it's certainly true that I think the clean water, the clean water is a very good example because it needs money, right? It's not cheap. Sanitation is even more expensive than clean water. And it's something we could all agree on that needs to be done. I mean, there's no question about that. It's probably not a high priority for a lot of governments because their constituents are not among the poor people who are suffering from this. And, maybe you can nudge them into doing better on this. But I'm a little bit skeptical. But I agree on the point that the clean water would be a great place to focus. How you get it done, I don't know.
No, I mean, actually, I like the clean water example, too, because it's a good example of something that you really do need, ideally, a government to get involved with. It's not something that local NGOs or individuals are going to be able to do a great job with. And it's very easily measurable. So, that would, if you're going to bet on one thing that might work, or at least that you could track over time, that might be a good thing to do. Any questions on water issues?
It will certainly have a big impact on health, and especially on children.
If we can do it with the virus, the NIH has put $34 billion into that one virus. The NIH just didn't find antiretrovirals. $34 billion taxpayer money into that one little virus. So we can target things. We know how to do that. We just rarely do it.
That's a good point to end on, I think, since this is something I've heard Ingrid say before as well, right? That to focus solely on children who are dying of AIDS, right, sort of denies the fact that there are so many children who are dying of things that we know what to do, we're just not doing them, right? So I think that's sort of a good point to end on. And we thank you all for coming. There's a celebration out in the Bernstein Gallery of art from Philani. So please stay for the reception if you can. Thank you.